Application of short leg cast, below knee to toes. Walking or ambulatory type. The physician applies a cast below the knee to the toes. The physician positions the ankle at the desired angle. Cast padding is applied from the toes to just below the knees. Casting material is moistened and applied to the leg in an overlapping fashion and allowed to dry. Application of long leg cast, thigh to toes. Walker or ambulatory type. The physician applies a cast from the thigh to the toes. The physician places the ankle and knee at the desired angle. Cast padding is applied from the toes to the upper portion of the thigh. Casting material is moistened and applied in an overlapping pattern from the toes to the upper thigh and allowed to harden. Application of patellar tendon bearing, PTB, cast. The cast is constructed to transfer weight to the upper tibia rather than the shaft of the tibia. The physician applies the casting material so that a shelf is formed under the tibial tuberosity/patellar tendon to bear the load of the cast. The foot is also included as part of the cast. Application of rigid total contact leg cast. The rigid total contact leg cast is applied to feet and legs demonstrating venous stasis ulcers. The method and cast material used varies with the applicator. Sometimes wound dressing must be applied over the ulcers prior to application of the cast. The cast begins at the foot and extends to just below the knee. Application of clubfoot cast with molding or manipulation, long or short leg. If applying a cast to the right foot, the physician uses the left hand to grasp the right heel of the patient, placing the thumb over the talar prominence. The physician's right hand grasps the forefoot. The thumb and index finger hold the metatarsophalangeal joint of the great toe and longitudinal traction is exerted on the forefoot. At the same time, gentle pressure is exerted over the head of the talus. After 1 to 2 minutes of traction, the foot elongates. It is held in this corrected position while a cast made of fast-setting plaster is applied by a second person over layers of sheet cotton. The cast may be applied only to the foot and connected to the leg in separate parts, or the cast may be applied at one time. If applied to the left foot, the physician uses the right hand to grasp the heel. Strapping, unabud. The physician prepares the semi-rigid dressing by first making a paste of zinc oxide, gelatin, and glycerin. This is applied to the skin of the leg. A spiral or figure-8 bandage is wrapped evenly over the leg. Paste is reapplied and further bandages are applied in the same fashion until the desired rigidity is obtained. Elastic bandages are often added to the dressings for reinforcement. Application of multi-layer compression system, leg, below knee, including ankle and foot. Upper arm, forearm, hand, and fingers. Removal or repair cast. Codes for cast removals should be coded only for casts applied by another physician. Removal of bivalving, gauntlet, boot, or body cast. Full arm or full leg cast. Shoulder or hip spica, Minerva, or Risser jacket, etc. The physician removes or bivalves a cast. These codes are used to remove a cast or to simply cut it in half for the purpose of using one half the cast as a splint or for intermittent immobilization. A manual cast saw is used to make 2 cuts in the cast. One cut is extended along the medial edge of the cast. The second cut is extended along the lateral edge of the cast. These cuts are started proximally and are extended distally. Once the cuts are made, the cast may be removed. Repair of spica, body cast, or jacket. The physician repairs a spica, body cast, or jacket due to normal wear and tear, revision of the cast or jacket, or the cutting of a window to check the status of a wound, incision, or other area. Additional casting material is applied in the normal manner. Windowing of cast. The physician chooses this procedure to check the status of a wound that is underneath the cast or to visualize an area under the cast where infection may exist. A cast saw is used to cut a section in the cast. This is removed to create a window. Once the status is determined, the physician may reinsert the section and hold it in place with casting material. Wedging of cast, except clubfoot casts. Wedging of clubfoot cast. X-rays of a cast, fractured extremity may show slight malalignment. Wedging of the cast may correct this malalignment without having to remove the cast. The necessary cut is made in the cast using a cast saw. A wedge of plastic or wood is wedged into the cast cut to redirect the pressure of the cast on the fracture site to correct the bony deformity. Adding walker to previously applied cast. The physician adds a walker to a previously applied cast. Lower extremity casts may be modified for walking with the addition of a walker. There are two types of walkers available: 1, those made of hard rubber and incorporated into the cast, and 2, those applied over the cast like a shoe or boot. If the rubber walker is used, it must be secured to the cast with additional plaster. Splint Application Part 1. A splint is also an orthopedic device, but it only partially encircles and encases a limb. It used in orthopedics to hold a limb completely still while a broken bone or injured limb is healing. Code only custom splints, whereas prefabricated splints are not coded. Custom splint indicates that the physician or other provider created the splint specifically for the patient's situation. Prefabricated splints are ones that are stored on the shelf and come out of the box ready to use. It is otherwise known as ready-made splint. Splints. A splint can be easily removed because it is usually attached to the limb using Velcro straps. This also means that the splint can be easily adjusted to accommodate a limb in which the swelling has gone down. Splints can be custom-made or pre-formed. Custom splints are often made with plaster, fiberglass, or aluminum, each secured with an elastic or self-adhesive wrap. Pre-formed splints are often made of hard plastic and Velcro. These can include the air splints, or air casts, and walking boots.
A cast wraps all the way around an injury and can only be removed in the doctor's office. All casts are custom made with fiberglass or plaster. A splint is like a half cast. The hard part of a splint does not wrap all the way around the injured area. Splints can be custom made or pre-formed. Custom splints are often made with plaster, fiberglass, or aluminum, each secured with an elastic or self-adhesive wrap. Application of long arm splint, shoulder to hand. The physician applies a splint from the shoulder to the hand. A long arm posterior splint is used to immobilize a number of injuries around the elbow and forearm. A cotton bandage is wrapped around the forearm from the mid-palm region to mid-arm. Plaster strips or fiberglass splints are applied along the back of the arm and forearm, maintain the elbows and wrist in the desired position. Application of short arm splint, forearm to hand, static. Dynamic. Cotton padding is applied from mid-forearm to the mid-palm region. Plaster strips or fiberglass splint material are applied along the palm side of the hand, extending to mid-forearm, maintain the wrist in the desired position. An ACE wrap is applied by the physician to hold the splint material in position. Report 29,125 if the splint is static, keeping the wrist totally immobilized. Report 29,126 if the splint is dynamic, allowing some movement.